Well, good morning, everybody, and thank you for coming to the Cardiovascular Research Institute Research Day and Medical Grand Rounds. And I'm Dr. Justin Ezekowitz. I am a professor of medicine in the Division of Cardiology, and I will be leading today's charge, but we'll get right to Medical Grand Rounds in a moment. For those of you who are here live in Kate's, you can scan the program and see what's going on. Those of you online will present to Department of Medicine Grand Rounds as per usual. So welcome. We just from a land acknowledgement perspective, you've all seen the Department of Medicine's land acknowledgement plenty of times. You're welcome to read it. I would ask people to, for those of you who are here in the Cates as a land kind of acknowledgement, walk outside to see Jason Carter's great artwork, which is in the building, and he paints a lot of the visual landscapes quite well. And it's a much better way to reflect on the way the First Nations has an impact on Canada. So that is a good land acknowledgement for people to think about. And as Dr. Ross will present a lot about Indigenous health today. So let me introduce Heather, who is a professor of medicine from the University of Toronto. She has many accolades, so we will not read off all of them, but just a few of them are that she received the Order of Canada in about 2020. She's been instrumental in the heart failure and transplant community for quite some time. And she's also the head of cardiology in the University of Toronto's system and part of the Peter Monk Cardiac Center. She holds a Loretta Rogers Chair in Heart Failure, as well as a Pfizer Chair in Cardiovascular Science. Most importantly, she's an outdoors person, a wonderful human being, and has been really forward-looking in terms of how to change care in heart failure. So I'd like to present Heather as who's presenting the Joseph Dvorkin Memorial Lecture, Medical Grand Rounds, and the Cardiovascular Research Institute's first lecture. So Heather.
Thanks, Justin. So first and foremost, I think I just need to put this here. So, you know, I'm not a Maple Leafs fan, even though I work in Toronto. I'm a Canadiens fan, but I think all Canadians can get behind the Oilers. So I just thought that I would put that there, and wishing the Oilers the best. A real pleasure to be here for this memorial lecture. And I had a chance to review the names of others who've given the lecture, and I feel like I'm in just a really select crowd, and a great honor to have the opportunity to speak to you today. So from a disclosure perspective, and I'm not going to fly over the disclosure, I'm actually going to spend a moment or two talking about it. So I will discuss the use of remote monitoring technologies that do have Health Canada approval. I will also discuss remote monitoring technologies where we're being used in ways that was not addressed by their Health Canada approval. And I am a co-inventor of IP that has been licensed to Medley Therapeutics, which still doesn't exist as a company. But I do have to state that I've been an investigator on Medley for more than a decade. And so it does represent a conflict of interest. So from a knowledge gaps perspective, I guess what I wanted to set the stage for today is what is digital health, and how can we apply digital health to heart failure? So understand a bit of the burden of heart failure, understand some of the roles and types of remote monitoring that we might be able to use that could improve outcomes in heart failure. What has limited digital health, and how can we overcome some of that? And so thinking about the quintuple aim and what are some of the challenges to that. And then how do we think about implementing or scaling digital health to large population sectors? I think most of you are aware of this. We do consider heart failure to be an epidemic. 1 in 5 people over the age of 40. I mean, it's so bad that I have to raise my hand now. 1 in 2 people have been touched by heart failure. I can raise my hand on that one as well. The average life expectancy after diagnosis remains limited at about 2.1 years. 40 to 50% die in 5 years, 80% will die within 10 years of the diagnosis. And that's of heart failure. And then it is a contributing cause to death as well in a large number of patients. From an impact perspective, we can think about the societal and the economic damage, and you always want to start with the patient. So from the patient's perspective, it does irrevocably change the patient's lives. So high symptom burden, high burden on the caregiver, There are days lost to hospitalization, so days off work. There's a high cost to medication and medical support. In today's day and age, sometimes that means I take my pills or I actually put food on the table. And the high mortality that we've talked about. From the provider impact, one of our goals always is to get our patients on the best medical therapy. And frequently that requires many visits for the patients. There's a highly trained profession, although maybe Justin is the exception. In-depth patient education is required, the frequent admissions and medication titration. And from the payer impact, it's about $3 billion right now in Canada, and that number is expected to rise. And the 2024 US statistics just published show that the absolute rate of heart failure is going to increase from 2.7% of the population to 3.8%. So we're in a growth industry. A lot of that has to do with the aging population. This is the traditional trajectory for heart failure. And I take this from Sarah Goodlin. A patient is diagnosed, and then after the diagnosis, they have an improvement in their physical function, usually through the use of medical therapies. But that period of time that the patient is stable is variable for every patient. And then the disease is characterized by this exacerbation remission style until patients reach end of life. And if we think about the way that we've actually been managing care in heart failure, we provide it in episodes of care. We book the patient into a clinic, we see the patient, and then we book a follow-up. For a stable patient, it might be in a year. For some patients, 6 months, maybe 3 months. But it may only be blind luck that we actually catch the patient sick at that time of a routine scheduled appointment that was booked 3 months previously. So one of the things that we've been extremely interested in doing is changing this paradigm of care, where we go from these booked episodes of care to on-demand care, where we're actually trying to identify the patient at moments before the decompensation happens, so we can intervene in that moment and actually change the trajectory for the patient. And this is really how I want you to think about where digital health can actually help. So for me today, digital health is going to include mHealth, health information technology, wearables, telehealth, telemedicine, and some personalized medicine. I'm not going to speak about implantable monitoring. That in itself is a whole separate topic. But it has the vast potential to improve our ability to accurately diagnose, treat, and monitor disease and disease progression, and to enhance the ability to deliver care for the individual. And in particular, meet patients where they're at. Many of the most popular digital health devices that we have on the market are pretty simple, measuring vital signs. You know, the holy grail of getting wearables to do blood pressure is still around the corner. And a lot of the health parameters also can relate to circulation. We recognize that there's a big difference between consumer versus medical grade versus population tested. This has a big issue when people talk about, you know, this device does this, and whether or not it actually does what it's purported to do. And I think one of the most important things, and crucial when you're looking at a chronic disease management, is that we need the active engagement of our patients, because if they are not engaged in what we're trying to do, then whatever the technology is that you're trying to use won't work. So this takes me back to the beginning in 1998, and this is what remote health, this is what, you know, digital health looked like. We printed out a piece of paper for the patient. We had this ideal goal weight that we were aiming for, and that was their maintenance diuretic. And if their weight was lower, we dropped it. And if the weight was higher, we upped it, effectively a sliding scale. And, you know, it worked. Okay, so it actually worked. But along came this thing, you know, known as technology, and we started to look at maybe we could do something better. And so one of the earliest trials was the tele-HF trial, and this was a telephone-based interactive voice response system that collected daily information about the patient's symptoms and weight, and then was reviewed by the patient's clinician. And this study, as you can see, the curves are all superimposed upon each other. This was a negative trial. And importantly, when we look at it, 14% of the patients didn't use the intervention at all, and 45% of the patients did not adhere to the intervention. So getting back to this patient engagement, if they're not going to do it, how is it possibly going to work? So the next big study that came along was the BEAT-HF trial. And this combined health coaching, telephone calls, and telemonitoring. So a little bit more engagement with the coaching to try to get that teachable moment, if you will, with the patient to understand their disease. But a huge challenge here was that of 30,000 patients assessed for eligibility, 29,000 were actually excluded. And so, of course, the question becomes, how relevant is this going to be to you in your clinic environment? And the curves were all superimposable again for readmission at 30 and 180 day and mortality at 30 and 180 day. So this is another negative trial. The way it worked was the devices automatically transmitted data back to a central server for telemonitoring review by telephone call center study nurses that were based at the primary study site. So it was sort of a 9 to 5, Monday to Friday type system. And of course, why didn't this one work? Well, it wasn't integrated into physician practices who are actually caring for the patients. And again, the adherence was only at about 60%. So 40% of people did not adhere to the actual intervention. And I would submit to you that this is probably because this is just a little bit better than the paper that we put up on the fridge. So this is now 2016. And if you were in the field at this time, you were actually wondering, what am I doing? Right? We've had these very large, properly designed clinical trials, no benefit. And then thankfully along came TIMHF2, which did show a benefit. And this was a large study and a bit more engaged, right, in terms of how the interaction happened between the clinical team and the patient. So they actually looked at, from a remote patient management perspective, they had a 3-channel ECG, blood pressure, weight, and oxygen saturations. They ran a telemedical center, which was well-staffed during the week. And on after hours on weekends, they had 1 physician on staff. So a bit of a warm line, but because patients don't know only to get sick Monday to Friday, it allowed for that additional coverage off for the patient. They also used tailored support and predefined algorithms to try to help ensure appropriate management. And as you can see here, looking at the cumulative event-free for all-cause death, the remote patient monitoring tool was significantly improved outcomes. They also looked at something that's become increasingly popular, which was the percentage of days lost due to unplanned cardiovascular hospitalization or death from any cause, and showed a significant improvement in the remote patient management arm. So this was pretty exciting. This has been followed through very recently by a systematic review and meta-analysis. Lots of challenges with those, but just to show here, it literally just made it to being significant in terms of using a remote telemonitoring, telemedicine to improve cardiovascular-related mortality. And then looking at a combination of both remote patient monitoring and consultation, a reduction in CV-related hospitalization in heart failure patients. So breathing a little bit of a sigh of relief that there is the possibility of benefit. When we looked at things just a little bit differently. And it was this idea that, phones are ubiquitous. I'd love to say that this quote was mine, but it isn't. John Cleland said, when you look at the smartphone penetration, why don't we enlist the help of the largest healthcare workforce, which are actually the patients? And so that's what we tried to do with Medley. So looking at Lynn Warner Stevenson's circle about remote management of heart failure, what she said was that the further you have to go over to the right is the longer path of action. So when the patient enters some physiologic indicators and they transmit that information, they throw that information over the fence, depending on who the team is that's able to actually make the decision, you can add time and more time and more time, so that by the time the information gets back to the patient, it may no longer be relevant in terms of how the patient needs to be managed. So we decided to take this and really just science the shit out of it. And so we created a rules-based expert system that accomplished this whole side of the equation, such that when the patient entered their physiologic indicators, it went into the rules-based expert system, and in that much time, the information got back to the patient with what their alert and what the recommendation was. And this is basically what Medley is. So Medley actually encompasses both the system, which is the rules-based algorithm, which is an in-app device that lives on the patient's phone, and the service, which is really the clinical delivery program support team or the nurse coordinator team that are used to operationalize the Medley system. The algorithm was based a decision tree. It is an expert rule system or a form of assistant AI. And the whole purpose behind it was to mimic the clinician decision-making process or act as a clinician proxy. So the way it was developed was scenario after scenario after scenario, and then asking clinicians, what would you do if this patient was in front of you? And then just going through that in an iterative way until this rules-based algorithm was created. Now, this is assistant AI, so the challenge here is it can really only handle a limited number of factors, but it does generate the self-care feedback based on individualized thresholds. And anytime the parameters fall outside the thresholds, an alert gets sent to the patient. We built it to be conservative because we don't want to miss patients who are sick. So one of the biggest challenges that we have at the moment is with it generating false positives. We did a look back, and from a patient alert status, what we saw was that 80% of the time patients are well. I think most of us know that. Heart failure patients are well most of the time. 20% of the time, it was a caution alert, meaning that the parameters were outside of the range. It might have been something as simple as some minor symptoms, and the messaging would have been, take your readings later today if you're feeling unwell, or it might have been, the weight was above and the push instruction was actually to take a dose of furosemide. Very rarely did we have a critical alert. That's the classic combination in heart failure that worry us, for example, of a high weight and low blood pressure, because we're very concerned that might be heralding a cold and wet scenario, or if a patient's defibrillator went off or they fainted. Because the algorithm does most of the work, we individualize things at onboarding, and because it does most of the work, the actual ratio for us for a Medley coordinator is to 250 patients. So most RPM systems are one nurse to about 60, maybe 80 patients, but we're able to magnify that by letting the algorithm do the work, and it is a Health Canada Class 2 medical device. The patient application is very simple. It was done using user-centered design. This is just an example of a patient who's entered some information and received an alert. Pretty straightforward for the patients. Our adherence rates have been very high. They do receive instant feedback through the app, so immediately in the moment, and they can monitor their own trends over time to see what their history has been. And from the clinician's side, we get to see what the alerts are. Anybody who has alerted bubbles to the top. So although we can review all of the patients, the nurses can actually focus on the patients who've had an alert who are actually unwell in order to actually interact with them exactly in that moment. So using Medley, we were able in a pragmatic study to show a reduction in heart failure hospitalization, a reduction in all-cause hospitalization. We think that's probably because of the similarity of symptom burden, concomitant COPD, a history of shortness of breath. The nurse coordinator will see that symptom and can maybe appropriately direct the patient for care for that. And for the patients who did end up being directed to hospital, their length of stay was 2 days shorter. From the patient's perspective, we showed an improvement in quality of life. This is with the Minnesota Living with Heart Failure, not KCCQ, but we were able to show that and an improvement in self-care. So this is just an example of where we've taken simple remote monitoring, created an expert rules system, embedded it in a smartphone application that lives on the phone, individualized to the patient, and how we can potentially improve outcomes. And we've had over 2,000 patients come through the Medley program. So let's move to GDMT, which is, guideline-directed medical therapy, and how might digital health help this? So first and foremost, why does guideline-directed medical therapy matter? And I just love this paper, which looked at comparing comprehensive therapy or quadruple therapy or GDMT, foundational therapy, all the terms that are used, and they compared that to just ACE/ARB, beta blocker, and did a cross-trial analysis. And really, the thing to focus on is that if you're a 55-year-old man, comprehensive therapy could improve your survival by 6.3 years. So that matters, right? That absolutely matters to you. And if you look at it here, it is the same message. So if you're able to get on foundational therapy, you have a 1 in 20 chance of dying in a year. And if you're not actually treated, you have almost a 1 in 5 chance of dying. So foundational therapy truly matters in the setting of heart failure. And yet we know we are still not doing it. So this is data from the CHAMP registry, which is real world data. And we can see even in their longitudinal, the target doses achieved at 12 months amongst eligible patients are low across ACE, ARB, beta blocker, MRA, and ARNI. And this didn't even include SGLT2 inhibitors. So definitely this is a challenge. And a most recent publication looking at patients at discharge from hospital, 42% of patients did not receive all recommended heart failure medications at discharge, particularly more so in women, in minority, and in those receiving care at urban hospitals. So this is basically an opportunity for digital health tools. So a lovely study was the PROMPT-HF trial. And they looked at over 1,300 patients with HFrEF, 100 providers, and this was geared at providing the information to the providers. So the alert notified the providers of individualized guideline-directed medical therapy recommendations, along with the patient characteristics. And so you had the characteristics at the top. The patients were seen in the outpatient primary care or cardiology clinic, pretty straightforward inclusion criteria, randomized to seeing the alert or not seeing the alert, and then looking at the outcome. And you can see that the proportion of patients on GDMT increased over 30 days. So think about Alberta, think about Cerner, think about a simple text messaging prompt and how something like that could be applied at a provincial level to try to improve GDMT. We did a randomized trial with Medley where we randomized patients who were on Medley but not on GDMT to either have usual care where they came in to see the cardiologist or could have those visits done virtually, or a protocolized Q2 weekly remote optimization using the information on Medley because we have the trends on their vital signs, their blood pressure, their heart rate. And what we were able to show is that we did get many more patients to GDMT faster. And I want you to hold on to this message because it's going to become relevant shortly. We were able to do it with 40% fewer visits. So just another example of digital health to get to GDMT. So we want to get there, right? We want to get to the quintuple aim. And in order to do so, we do have to make health equity an explicit goal. And in doing so, we can actually improve health and improve the economy if this is a focus for us. So this is one of the biggest challenges with digital health, right? Is the so-called digital divide. And I think it's important to think about it, especially in the Canadian context, our geography and some of the challenges, some of the structural issues that we have. But clearly access to the technology is huge, how we democratize the technology across the population. Things like broadband, which is, a social determinant of health, actually. And, thankfully, Starlink can say what we want about Elon, but Starlink has made a very big difference for a lot of the remote northern communities. Skin color and wearables. So even medical grade SAT monitors have clear issues with skin tone across amongst skin tones, and they do not accurately reflect oxygenation in people of color. So how do you look at that, and how do you figure out ways to develop new monitoring strategies that will actually be equitable across skin tone? What is health literacy? In Canada, with principles of OCAP, how do we deal with data sovereignty? So these are all crucially important issues. We did a look back on Medley, and the ON-MARGE is a validated index in Ontario. And what it uses is the dissemination area, which is the smallest standard geographic area for which all census data has been disseminated. So it's the smallest area you can do that. And then they use that, they can extract the corresponding dimension of marginalization in quintiles. So thinking about things like material deprivation, housing, educational level, they can base this based on this small dissemination area, and this has been validated. So we were interested in the first 1,100 patients who came through Medley, how we did in terms of being able to provide across really all areas of deprivation. And one of the things that we made a decision with Medley was that it didn't matter what you have when you came to be put on Medley, we would make you complete. So if you didn't own a smartphone, we would give it to you. If you didn't have a scale and a cuff, we would give it to you. If you had poor health literacy, we would give you a package where everything was already Bluetooth enabled. So there was really very, very simple system to use. And so we had all these different ways of trying to make a patient whole and providing that from the program. Now, this speaks to the penetration of smartphones. 62% of people had everything they needed to be monitored. We had to provide the full kit for just under 20% of people. And then 20% of people had a different package of stuff and stuff that they needed from us to actually make them complete. But then when we actually did the analysis, it was heartening to see that in actual fact, we hit all these areas of deprivation. And I'm just showing two here, which are residential instability and material deprivation. So thinking about how you deploy a digital health tool may actually help you broach the digital divide as opposed to worsening it. Another major aspect when you're thinking about a digital tool, which is fine that you're creating it and you're thinking about how it might be used, but of course you're implementing it in a population that may be far removed from where you work and where you live. And so a really important principle is the principle of community-based participatory research. And this is where we have transitioned from traditional research or this community member engagement, but no influence, through to all the way to the other side, which is a partnership and how we can use it to promote social change. So the patient goes from study participant to a research partner. And we had and we have a beautiful collaboration with Yale, the Uganda Heart Institute, and the Uganda Initiative for Integrative Management of Non-Communicable Diseases in Kampala. And we thought about, how digital health might be really relevant in low middle income countries. There's some beautiful data from Rwanda using digital health for fetal maternal outcomes that's shown a tremendous benefit. And when you think cost-wise, sort of this may actually be something that works. Now, smartphone penetration in Uganda, less than 20%. But if you look at a phone in Uganda and you look at homes, more than 90% of homes will have access to a phone. And if you have traveled to Africa, you will have seen something that looks like this. So we sent our team and embedded the team in Kampala in 2016 to think about how we might be able to adapt Medley for the local context. And we did a mixed method study of 101 patient surveys, in-depth interviews, visiting rural communities. But we came back to this issue here, which is, flip phone or straightforward phone penetration very high, and people trust mobile money. So very commonly used where people are working in a different city, different country, different environment in Africa, and they send the money home using a text-based system. They trust it and it is secure. So we built on this USSD SMS text-based system. We didn't change the algorithm for Medley because that is the clinician proxy, but we changed how the patient would see it in terms of it now being text-based and how that information would get to the clinician. So as a result of the pilot study, what we recognized that was feasible was a 3-time-a-week check-in. So the patient using simple text buttons using the USSD code would answer some simple symptom questions and still receive tailored advice through the phone. And we did a pilot study with NIH funding. What we were able to show at 6 months after initiation was a significant improvement in self-care maintenance, self-care management, and self-care confidence around their disease. And I should say that, the prevalence of heart failure is growing tremendously in low middle income countries. So we were excited to see these preliminary results. We had improvements in quality of life in the patients, reclassification of functional status, a reduction in hospitalization. Now, this is a pilot study. And one of the things Uganda hates more than anything are people that come in and do pilot studies, publish a paper, and run away. But we opted not to run away. So we were very fortunate to receive NIH funding to actually now do what's called Medley Uganda, which is a appropriately powered study to look at the benefit of this system in Uganda. We're looking at 6 regional referral centers because, the healthcare in Kampala and the access to and how it's done is very different if you've traveled to some of the smaller communities, which are often forward nursing stations. The question is whether or not we'll be able to change the outcome. So stay tuned. That has just been launched. We've got an Echo AI, an ECG AI piece, a lot of really interesting pieces that we've added, point of care biomarkers. But just the highlight here is how Medley could be used. And then, Justin did mention that I was going to talk about some of the work that we've been doing with our Indigenous partners. And appreciate the land acknowledgement. I think it's always important to remember this is Indigenous History Month, to remember the very important statement of nothing about us without us. And I will read it out. So self-determination and participatory approaches to health promotion are essential to move past the effects of colonization and facilitate sustainable change with Indigenous peoples. It is essential that well-intentioned healthcare providers, us, or policymakers partner with Indigenous communities to define the problems and the solutions. And we were very fortunate to engage in a partnership with Winnebago Area Health Authority using community-based participatory research. This is the Moose River, just to give you an idea, Moose River at sunset. But, just to put some perspective around it, and I know there are fly-in communities here in the north of Alberta as well. But if you live in Peawanuck, which is the top community, which is actually on Hudson's Bay in Polar Bear National Park, it is a fly-in community. And so if you want to get to either Toronto or Kingston, it involves 3 to 5 hours, multiple times with multiple layovers and at least 1 to 6 stops. So if I'm trying to bring an elder out of community, I need an escort. And those 2 individuals, it's a day plus and a half of travel out and a day plus and a half of travel back in. And it doesn't really matter what you're trying to do in that community, they have to come out. And so we've looked at every way for travel. You can drive up to Cochrane, which is 8 hours north of Toronto, and do a 5-hour train, which is known as the Polar Bear Express. You can bus. And then in the winter, we drove the Ice Highway from Toronto. We drove it all the way up to Fort Albany, and that was an 18-hour drive on the Ice Highway, which was quite an experience. But it gives you an idea. 5 of these communities you cannot drive to. And Moosonee, you can really only drive to in the winter. So we did a number of sharing circles. We had a local REB, and the purpose of the sharing circles was really to explore the needs and the priorities of the community. We had a lot of interest in how digital health may help us meet patients where they're at, but we recognize that the priorities for the community may be water, maybe the issue of the opioid crisis, maybe mental health. And it may be that even though we're very excited to bring and to work with them to bring technologies forward, it may be that that's just not important to the community. So we felt it was really important to start with the Indigenous sharing circles. And they were incredibly powerful. We held a number of them. And I would summarize the findings that, heart health is more than just metrics, that we have to honor their previous traumas. We have to destigmatize care through relationship building, which is something we've been working on with this community for almost 7 years. And we have to think those innovative solutions have to start with the community. So this again gets back to the role of community-based participatory work. And so as a way to do that, Medley was one of the tools that we use. We translated it into Cree, and we translated the peripherals into Cree. We had all of the information provided through an audio in Cree in case people were unable to read. We created graphics for the community to explain what we're doing. And this has been one of the most fulfilling projects that I've been involved with. And since those sharing circles, we've been able to leverage Ontario Health funding, so provincial funding, and also funding from Boehringer Ingelheim. And the goal really was to bring the cardiology care closer to home. We're now up to 4 in-person clinics per year where we take at least 4 or 5 practitioners and a sonographer. We were up there last week and saw more than 100 patients and did more than 40 echoes. We have more than 100 patients on Medley. We've launched an NT-proBNP as per CCS guidelines. screening committee, so the screening program actually, so that if the NT-proBNP is high, we can triage those patients for review, trying to get at issues related to prevention. We use Apple Watches up there. We receive CFI funding for infrastructure, so we can use Apple Watches for AF detection in the community. The portable echo cardiostat patch holders, so makes it very easy. People are out in the bush. We can still see what's happening from a Holter perspective. Obviously, we have POCUS up there, and we've just started with the ring-based OSA screening program, so we can try to minimize people coming out of community for sleep studies unless they screen positive. So these are some of the ways that we've tried to leverage Health Canada clinical digital health tools to improve care for patients where they're at. So this is my terminology, the sextuple aim. I just thought I would say that, but all of this discussion still gets us back to how can we do this and have sustainable healthcare? And you may be familiar with the COP28, which was the UN climate change conference, with the quote that I think is very important, which is promoting steps to curb emissions and reduce waste in the health sector, such as by assessing the greenhouse gas emissions of health systems and developing action plans, nationally determined decarbonization targets, and procurement standards for national health systems, including supply chains. We need to be thinking about how we're going to do sustainable care in this process. So I'm not sure if you are aware, but the health care industry contributes 4.4% to the world's CO2 emissions. And in Canada, we're at 4.6. The US is the highest. There are three scopes that they think of when they think of CO2 emissions: direct healthcare, operational emissions, purchased electricity, gas, heating, and cooling, and only in order to run hospitals, et cetera. And scope 3, which I've shown here on the right-hand side, which are things like water treatment, transportation, pharmaceuticals, and the development of the same, other manufacturing. This is huge. So I have talked a lot about digital health, and I focused on the digital divide as one of the concerns, but let me just talk a little bit about this. So digital health is not free, right? We're all here with our phones and we're on them, and we're thinking digital health is free. So material mining, where do most of the compounds come for the digital health tools, the GPUs and the things that we use? They come from Africa and they come from South America in areas of exploitation and deforestation of the Amazon, et cetera. So just further dealing with issues related to colonialism. Data centers and underwater cables require a tremendous amount of power. The energy consumption is off the charts, and I'll give you some examples. And of course, waste. So all these things, when we get to the next phone and the next phone and the next phone, and the waste that is generated has created an entire subculture with where the waste is going, what we call digital dump sites. Okay, I love this one. So if you look at the up in the right-hand corner, right, the time to 1 million users. So Spotify, it's like 150 days. It took 5 days for ChatGPT to get to 1 million users. 5 days. And training ChatGPT 3 estimated to consume more than 550 tons of carbon. That's in the training of it. So that's New York to San Fran and return 550 times. ChatGPT 4 has 570 more parameters. So it's going to be way more carbon. Oh, sorry, that didn't turn out with the anyway. Google AI represents 10 to 15% of their power use, and that's only going to continue to grow. So you think about the size of Google AI, 10 to 15% of their power use. And this is probably my favorite, which is the water consumption. You've got to cool things. So you got to think about your water consumption. So for every 20 questions ChatGPT is asked, it takes a liter of water. A liter of water. So why does that matter? ChatGPT responds to 200 million requests per day. So our next big resource limitation is water. Now we have a man from the Netherlands in the room. So let me give you another favorite example. Bitcoin development uses more energy than the entire Netherlands. So we don't think about that, but digital health is not free. So I'm just going to give you a bit of a taster about what we did, which was in this 40% fewer visits with Medley. What did we do with that in terms of carbon? So this is called Medley Carbon. We used a validated carbon calculator called Cascades, and we looked at the group differences in that Medley titrate arm. So let me walk you through this. So this is the usual care here on the left with in-person encounters. They still were able to do virtual encounters. The Medley calls are those patients on Medley where the nurse had to call or follow up because there was an alert for something. The MD calls are actual MD virtual encounters. In the Medley arm, we had many more encounters. So we had 518 virtual encounters. You'll still see the same MD calls and Medley calls for purposes of Medley telling them something was wrong, but you had 293 remote titrations in the Medley arm as part of the actual protocol. So what does this actually translate to? Just in this relatively small study, 7,000 tons fewer in order for us to titrate patients using Medley as a digital health tool. So if you think about your digital health tool and you're able to do remote titration, think about how that might actually benefit from a sustainable health perspective and a significant reduction in travel. So pretty exciting stuff. And I think we have to be thinking about the environment. My final sort of teaser, as I've just told you how much AI uses in terms of energy, is a partnership that we've had with Apple. So, you know, a while ago, Yaz, Dr. Moyadi, when she was a fellow, did a pretty straightforward project looking at the relationship between Fitbit and Apple and our ability to distinguish functional class. And not surprisingly, you know, based on daily steps, it correlates reasonably well with functional class. And that got us thinking about how we could use wearables. So going from Medley, which is a once in the morning assessment of the patient, to near continuous monitoring through using a wearable. And maybe that would, you know, changes in those step counts would herald the onset of symptoms, and we could basically develop a new monitoring tool for earlier intervention. But we went deeper into some of the information and did some feature extraction. And it's kind of cool here because this is, obviously a well patient who's NYHA. One, you can see the heart rate and you can just automatically see the heart rate variability, right? And then you've got the step count below. And as you get to a patient who's functional class 3-4, you can just visually see the difference in heart rate variability. So that got us thinking about what more we could do with something like the Apple Watch. And so we started the TrueHF study. This is in partnership with Apple. And the question we asked was, do Apple Watch biosensors alone or in aggregate predict cardiopulmonary exercise testing, which is our gold standard to understand a patient's prognosis? Can they predict hospitalization or other markers of risk like NT-proBNP or the Seattle heart failure model? And what I can tell you is that it works. So this is generative AI using a transformer model based on the information that comes out of the watch. I'm not going to tell you which bits, but what we were able to see here, that's the AROC curve for the algorithm we developed, which is WEAR-HF, in terms of its ability to predict peak VO2 and changes in peak VO2. Unfortunately for Apple, you can see that the Apple Watch is right along the line of not working. Now, from an Apple perspective, the good news is we use parameters from the watch to be able to create a really awesome algorithm that does actually work. And from a teaser alert perspective, this is what's most exciting to us, which is that when somebody had VO2 drops on the basis of the algorithm, so it takes 30 days of data to predict the next day, and it rolls to predict the next day. That's the way the algorithm worked. And when it predicted the drop, we saw a 3.7 and change fold odds ratio for hospitalization. This was not an intervention study. It was a strictly observational. And the next plan is to move to that other state. So guys, I've just touched on some small things and focused a little bit more on what we're doing, but it is wide open. You might have seen the very recent article looking at seismocardiography by putting the phone over your heart as a way to detect risk of heart failure. There is a lot happening in the AI space on ECGs and on POCUS, the ring-based facial detection of blood pressure, edema in the vocal cords, changing voice, changing the timbre of the voice or the way the words are spoken, and how that could predict heart failure. There is an awful lot happening in the space. And I think, when we think about what is digital health, I hopefully have given you a bit of an overview. I think it can be applied to heart failure to truly benefit patients. But importantly, as all of these come out, we have to evaluate them. We have to appreciate if they're hitting the value proposition, which is back to my very early slide. Are they changing things for patients? Are they changing it for the provider? Are we changing it for the system? Because if we're not, and the system for me also includes sustainability from a climate perspective. So we have to be evaluating those things appropriately. I think we can do it. I like the six-tuple aim. I'm kind of fond of that word. And I think we can scale to a population level, and that depends a little bit on the price point. So one of the concerns we have with the Apple study is that a watch and a phone becomes very expensive to roll out in a lower middle income country. But what if we don't lose too much on our AROC with a Fitbit? Now you're talking about something that could be rolled out at a totally different price point and have much more scalability. We have to bridge the digital divide. It has to be forefront in our design and our thinking. And of course, we have to think about healthcare sustainability. I'd like to thank all of the partners who've been involved and the team. The great thing about speaking is I get to talk about what everybody else did, which is always an honor. Thank you very much.
So thanks, Heather, and it's amazing the work you've done. And thanks. So I'm not 55, just so we're clear. We'll go through some questions from the audience. Just while people are coming up with questions, and I'll have a look online in a minute. But what do you think is the bigger challenge? Is it the first mile and coming up with the idea, or the last mile and the implementation? Where do you kind of fall on that paradigm?
So thank you. There are tons that are coming, but that last mile is absolutely right. That's the gap, and we used to call it the valley of death when you're thinking about other things. I think in technology it is the same, because you're there, you've got a technology, you've done user-centered design, you've had persons with lived experience engaged, you've done your CBPR, you've got something, you've shown in a study that it works, and then how do you actually get it from there actually out into implementation? And certainly that's been a journey. I've walked that journey, and so it really is I think it is the biggest area for challenge. But don't be daunted by it, because I think it's going to happen, right? With the growth of AI and with all of the information that's available. And when we start to actually incorporate other pieces from the phone, like what you're buying, the food you're eating, the potential here, I think, it's a little big brother scary, but I do think the potential is there. But that final step, for sure, is the hardest.
Thanks for that, Heather. Questions from the audience? Paul, the microphone coming to you.
Thank you. Thanks for an inspiring lecture and for framing these novel developments in a socially responsible way. The question comes back to the end user and the digital divide. And as you pointed out, talk to us about the state of readiness of the consumer, not only to participate in some of your thoughtful there's a sustainability one-on-one, after that 6 months of enthusiasm. What are your thoughts about the real world here and the broader implications?
So I very much appreciate that. When we started Medley, our feeling was, since heart failure is a chronic disease, the patient should stay on Medley for the rest of their life. And then, you sort of scale that up in your head, and your head wants to explode. So, when you think about it, the goals really are to get patient to guideline-directed care and improve self-care. And then if there are clear markers of patient improvement in functional class, improvement in biomarkers and/or EF, We have an offboarding protocol, which then, the hope is they'll go back into the free world, having learned from the program, and be followed by their family doctor, by their local doctor. So the thing that we did with Medley, which I like, I call it the safety net. So the app is still on their phone, but they've been offboarded, and let's say 9 months later, they're not feeling well. They can open the app on the phone and enter 9 months later that they're not feeling well, and it'll automatically alert. So even though they've been offboarded and discharged from the program or even discharged from our clinic, if they're out there and something happens, they can actually start the app and it'll still alert. So it does provide, for me, a little bit of a safety net when you think about the longer term. So that's just an example. Certainly with the work that we've been doing up in Winnebago, the tools that I think have had the most resonance there have been this idea of not having to leave community. So when we're up there with POCUS or with the full ultrasound machine, especially in Peawanuck, doing the echoes, it's one thing. So it's very easy for the community to be engaged with that. The AF watches have worked pretty well. We've had a lot of patients. We met all our targets for Medley. But, as is often the case with digital tools, as time goes by, people start using them less and less. And certainly we've seen that. The population that stuck before we did offboarding, the population that was the most adherent to Medley for the longest period of time is actually the age over 70. Right? So maybe the group that you would have thought was not technologically advanced is actually the group that at a year had like 65-70% adherence. At a year out, and that's taking daily measurements. So you have to be a bit pragmatic, and maybe we don't need daily measurements. And I think this is all to be sorted as things, as they say, the real world has a voice. So there's trial and there's sort of how you do it, and then throwing it out into the real world. Sometimes it doesn't survive that first contact. So it's really important to know that. I hope that answered the question.
I'm just going to have a quick peek at the.
Justin, while you're looking at the online questions, I'll just ask
Padma,
a question.
sorry. Like, where's that voice coming from? Padma.
Thank you for an excellent talk, Dr. Ross. Couple of questions. One is, we have shown that in heart failure, frailty is a major marker for outcomes. And we're actually showing that the patient can tell us about their frailty status. To what extent have you explored capturing that data from Medley? And my second question is kind of broader. I know after you showed proof of concept of Medley and how well it worked, you're getting funding to do additional studies. But the initial Medley, how was that funded? And is it an industry, academic collaboration, or how do we get there?
So thank you for those questions. So the initial funding for Medley came from something called the Test Your Limits program, which some of you may be aware of, which is where I try to die in a remote environment and people give money to our program. Is that a reasonable summary?
Yeah.
So that is where the original funding came. And then we got FedDev funding. So the original proof of concept, the very original study that Emily Cito did, which showed way back improvements in biomarkers, EF, quality of life, and self-care. That was all funded through Test Your Limits. But that initial pilot data leveraged FedDev funding. And so that made a very big difference. And there's been some other philanthropy along the way around some of the very specific projects. We have a number of AI projects and growth for Medley. But yes, it came from that. So, and that was back in a day when technology didn't appeal to CIHR. So you were a little stuck because they weren't really interested. In it. So that's how that was funded. We can talk more about that later. And then your second question, the frailty thing's huge. So one of the requirements for Medley is that you get a weight. So we've not had inclusion criteria for Medley. We've had only exclusion criteria. We've had, as I said, 2,000 patients that have come through. It's now the standard of care at a few hospitals in the city through the quality-based procedures program. But the elderly frail are still a challenge because they cannot stand unaided. We've tried bed scales, but the scales aren't very accurate. And so I don't think we've got that group right yet. But as you know, there are smart files coming. There are textiles that can look at bioimpedance. So there, Medley's, it isn't going to fix everything. I don't think there is one tool that will. So I think we have to be, again, you're back to community-based work, right? You're back to what is the environment, the context, and what am I building for that context? I think a point very well made. It's an area that that needs to be looked at because they are at highest risk.
So maybe I'll paraphrase these two questions. Then there's a question over from Sean Van Diepen after and here. The two questions are really briefly, are we worried about creating silos of care across different disease states? Heart failure is, of course, the most important, but COPD, chronic kidney disease, pick the other disease state. And the other part about virtual versus in-person care, do you think it does make a difference, or where do you feel on that?
So the first question for us is easy. You might ask us why we called the whole thing Medley in the first place, and it was because we wanted to manage a medley of diseases. So there have been a number of studies where it is out being studied for concomitant mental health issues and obstructive lung disease, and we have a module for chronic kidney disease. So in actual fact, by having a platform where all the providers can see all the information, some can have read-only access, some have read-write access or ability to change the parameters. It is a way to actually bring the team together. And of course, with Epic integration, then that's all. It's not, there's no duplicate. It's actually all there. So I think that's crucial. Otherwise, we are creating silos, and especially with SGLT2s and GLP-1s, it's going to be a disaster if we don't all know what we're doing. So that's the first one. And the second one, sorry, remind me again.
Virtual and versus
So
in-person.
it's this. I'm fighting myself because I'm an old lady and I really like seeing patients in person. So the virtual thing, I find it a little hard, but what the patients told us with Medley is that they see it as an extension of the clinic. They do not see it as technology being put between them and the clinic, and I think that's because of the touch that happens. And if it's for remote titration, for guideline-directed titration, I often think about what it must feel like to drive from Peterborough for 2 hours on the 401 and pay $25 in parking. You're going to get a blood test. If you're lucky, you're going to get 7 minutes of FaceTime. Let's be honest. I know I'm being recorded. Let's be honest. And then you have to reverse that whole process. So it's a whole day off work. Plus all that time on the highway for 7 minutes of FaceTime with me. I'm not that important. So if we can actually do that in a virtual way and then make the appointments where they need to be seen count. So it's the appointment where they're having their follow-up echo and their exercise test and a one-step shopping, then the appointment, that is face-to-face counts, and the other ones, I think can often be done that way.
Okay. Two questions from Daniel, then hopefully time for Sean as well.
Yeah, thank you, Heather. Clarity and challenge for us to see things better in the future. My question comes to family members and caregivers. We know heart failure, especially, how important they are in terms of improving medical adherence, well-being, and so on. How have you used the technology currently to actually empower family members and caregivers in a way to make their jobs easier, but also to decrease their overall burnout and stress?
So thank you. We recognized that was a big issue. And so sorry for all these names. We created Medley Care Town, which is an environment for the caregivers to be engaged across multiple languages. And in fact, I can play a voice bot for me speaking fluent Portuguese. So that process, having been identified in a multicultural city like Toronto, where there are many that aren't fluent in English, but the caregivers are, and how we can engage them. So I think it's crucial. Otherwise, we're going to fail. So I agree completely.
Sean Van Diepen.
Heather, fantastic talk. You're looking after patients in Northern Ontario, and I think all of the clinicians in the room, we do virtual visits with follow-up in the Northwest Territories. One of the challenges we have with these virtual care, and we use everything we can, whether it's a blood pressure cuff or an Apple Watch, is an underlying distrust of Western medical care or people that look like me. What have you learned with the implementation or design of these apps to help bridge that divide?
So you're absolutely right. And I was reflecting that Fort Albany was home to St. Anne, which is the worst residential school in the country. And Fort Albany is one of the Wienabaco area towns that we serve. You know, the first time we went up to community, I just went up to talk and to listen, mostly to listen, and was invited to camp and spent a day, you know, in camp and you know, just observing and listening, and then the next time we went up, we had a clinic and sort of, you know, if you wanted to come, I was there. And then we had a patient who was in distress, who we brought down and managed to get, you know, a cath, an AF ablation, echo, testing, all done in 3 working days, you know, which is a bit uncommon for a new patient. I think you could all admit. And he went back and he normalized his ventricular function. And Facebook is the communication of choice in community. And he put it on Facebook. And the next time I was in community, I was taking the water taxi. I was in the canoe water taxi going over to Moose Factory, and the woman on the canoe said, "Hey, you're that doctor from Toronto. Can I have my dad see you?" Right? And I said, "Sure." So, you know, I don't know how else to say it, Sean, other than to go and to listen. The whole team has had cultural safety training in multiple ways. Listening is what we try to do best. We book the patients differently, so the appointments are longer. Because sometimes there'll be trust and sometimes there won't be trust until a number of appointments have happened. But I think because we're not itinerant, which has been one of the challenge, because the same team goes up again and again, and we do keep coming back. And because we've been lucky to have some really big saves, we've been really welcomed by the communities.
Great. Thanks, Heather. And it is time for a break. So for those of us in the audience, I thank Heather very much for her wonderful talk. So thank you, Heather.